My name is Emma Nye. I'm an Indiana State University Doctorate of Athletic Training student. This is my lower extremity evaluation approach PowerPoint for ATTR 810. Really how my current evaluation looks in terms of evaluating the whole patient and the entire kinetic chain is my use of patient-rated outcome measures as the most information I get when I think of comprehensive evaluation. I use an array of patient-rated outcome measures both for the lower extremity and the upper extremity, as well as, for example, the global rating of change, which is not region or body area specific. It sort of encompasses the entire patient. I also believe my approach is very comprehensive in that I take pride and value into active listening to my patient. When an athlete comes in for an evaluation of the lower extremity, I take pride in the history portion of my evaluation. I believe that's my strong point, in that I do pay attention, make eye contact, ask probing questions to the patient's answers, make them feel comfortable, and know that the patient can ask me questions or slow me down at any point. In terms of the entire kinetic chain, really what I think of in my current approach to lower extremity, the number one most encompassing action I take is evaluating the joint above and below. So if we're evaluating the knee, I would take special consideration both at the ankle and the hip. However, there are some gaps to my current evaluation. Oftentimes, I believe that I'm being all-encompassing in my evaluation, but I know that there are several areas in which I can grow. The first being making sure that the patient knows that they can express their beliefs in terms of spirituality, other values, their cultural background, and what's important to them. While I do use those patient-rated outcomes to get a little bit of information from what's important to them and their perceptions of their own injury, at some points I think that I could be more encompassing with other aspects of their life. The second thing or gap in my evaluation approach would be the involvement of the family. In this recent semester, I've had several long-term injuries that the patient was out of participation for a long time, and while I can appreciate and work through the pain and suffering from being out of the sport that you love, I also know that it's very important for the patients to involve their family. So asking the patient, obviously with their permission, to involve their family if that's something that they're interested in, need to do a little bit better job at that. As well as evaluating the core and asking probing questions about their academics, which I'll go into a little bit more in depth now. So when looking at the literature, I found an article that was really interesting. It examined the importance of asking these spirituality, belief, value questions when evaluating a patient. Now, the article really did encompass the theory or concept that physicians and athletic trainers, it's safe to stick to science, stick to the physiology, stick to essentially what we know. But I think I would be unsure how to respond if a patient presented with a spirituality request. And this is difficult since we do have a multicultural society, an array of religions. But patients that are involved with religion, spirituality, do appreciate a different experience of illness. So as clinicians, we need to pay attention to these cues and make sure that they feel welcome to express any sort of concerns that they may have. And we do need to have respect for these experiences and perhaps different perspectives without sacrificing the science, what we know, the physiology. Another article I found to sort of close these gaps in my current approach to lower extremity was the involvement of the family from the Institute of Medicine's patient-centered care model. Like I mentioned earlier, I have had several patients that have asked me, do you mind informing my dad, or do you mind explaining this in almost layman's term to my mom or my sister, obviously with the patient's consent in maintaining confidentiality. I believe that is a really valuable piece to evaluation and also decision making. The article did say that patients and families are kept informed and actively involved in medical decision making and self-management. That's one part of their patient-centered model. Responding to patient and family needs. Maybe they have a different perspective, or they've asked questions and they need to feel that they have the right and ability to do that. They should never feel uninformed or disenfranchised, and they do have that very valuable first-hand insight into their patient, or our patients, their family members' preferences, which I thought was really interesting from the article. In terms of my approach to lower extremity, I do believe that I'm leaving out the evaluation of the core. And since it's an important component of nearly every gross motor activity, it is really important to evaluate, even when looking at the ankle, the knee, the hip. Is the core activating? Is it involved? Are we screening for those athletes with weak core that are perhaps predisposed to injury? So clinicians must be able to, and this is from the article, identify patients with limited core stability, utilize current methods for testing core muscle capacity, and specify an approach for advising these individuals, especially when we talk about injury prevention and risk factors. This is definitely something I need to include more in my evaluation approach. And finally, asking probing questions about academics to include the whole person. I currently work with collegiate athletes, but the collegiate athletes are student athletes. They're students first. And I do see a lot of patients coming into the athletic training room wearing a backpack on one shoulder, and they complain of low back pain or leg pain and knee pain. And it's not surprising when they're carrying 35, 40 pounds in their backpack worth of textbooks. So I did find an article essentially demonstrating that there's a significant trunk postural changes during backpack wearing, and there's a significant relationship between fatigue, low back pain, and a neglectable effect on lower extremity muscles. So I do believe that when my patients come in and I see them carrying their backpacks and they're complaining of these symptoms, maybe knee or lower leg, as there's a stat here from the article, I can assess their posture. I can perhaps educate them on how their backpack may be potentially detrimental to their lower extremity injuries. So in terms of actions, what can I do from here, my actionable steps? I can listen to cues for spiritual preferences and values, offer to involve the family in decision-making when discussing a plan of action with the patient with their permission. Start evaluating the core more, screening for those with weak musculature, and assess posture and backpack load.